Hi, everyone. Can you hear and see me? Well, see my screen at least.
We can hear you, but thankfully we can't see you. We can see your screen.
Okay, fantastic. Okay, great. So my topic is a granular problem, and I will be presenting on two patients that came relatively at the same time, and currently one is still with us in the ward. Okay, so case one is a 42-year-old male. He's employed as a truck driver, and he has a background history. He's HIV negative, type 2 diabetic with a poorly controlled HbA1c of 14%, but no known target organ damage, and he's overweight. He initially presented to his GP, and then he presented to Mitchell's Plain with this painful back that was not responsive to analgesia, and he had no history of trauma, no recent travel either. And importantly, at Mitchell's Plain, they examined him and they were a bit concerned about the swelling over the right side of his back, and was then further referred to Groote for further management. And I'm just going to show you a snippet of the CT scan that was done. You have to believe me when I tell you this thing was very large. And what you can see over here is these abscesses in his erectospinae muscles or spiny muscles. And importantly, at the same time, there was an effusion, pleural effusion on the right-hand side, but was thought to be more likely related to a neighborhood inflammation rather than to an empyema or an extension of this abscess. And for what it's worth, this pleural fluid was actually very small anyway, and the only way to get to it would have been via ultrasound tap. Okay, let's go to case presentation 2. So this is a 50-year-old gentleman. He's HIV negative. He lives in Plettenberg Bay. He lives in an informal settlement, and he's employed in the construction industry for many years, and has had animal contact with cows, sheep, and his recreational activities. He loves playing soccer. He presented presented in 2013 with left knee swelling, and his employer had taken him to private on actually multiple occasions in 2014, 2015, 2016, had multiple procedures done. He kept on telling me they would drain fluid from his left knee, but it would just keep coming back. He was then referred to George Hospital, in which a few biopsies were done, and then he was referred to Groote in 2018 again with more biopsies done. And unfortunately, it sounds like he was lost to follow-up for a bit of time, and I think COVID had a big problem with had something definitely to do with that one, but alas. So I'm going to show you some photos that we took at the end of last year. So this is the knee over here, obviously, and you can see there's a bit of a contracture, and then there are these ulcerative lesions over here. But actually, when you talk to him, he describes them to be things coming out. So I asked him what these things are, and he says, "Oh, sometimes this sugar stuff comes out." So I asked him what color these sugar things were, and he said to me, "No, they're sometimes yellow." So that definitely caught my interest. And once again, there's his knee on the left-hand side. As you can see, once again, these sinus tracts coming through. And I know it's not a great image, but I mean, you can compare it to the other knee, and you can see it's markedly swollen in comparison. And it probably went up to mid-thigh and all the way down to his ankle region. Okay, so let's look at some of these x-rays that he had. So in 2017, I can see some soft tissue swelling, osteopenic looking. Maybe there's an osteolytic lesion over here. But now let's compare it to what happened when we saw him in December last year. And you can see this marked increase in these osteolytic lesions all over, some osteosclerosis, definitely osteopenic bone. And once again, you can see a lot of soft tissue swelling, and the patella is also not looking fantastic. And this is the AP view, same time. So once again, you can see these cystic lesions, and then it's just a lot more profuse on this X-ray over here. All right, so we managed to do an MRI for him when he was admitted now for further management. And our plan initially with Prof. Loebscher in December last year was to take multiple biopsies and consider an arthrodesis that he could at least use the limb, because I mean at the moment he's essentially previously was using crutches to walk around and was unable to use the limb at all. And if you look at these MRI features, there's once again a lot of edema around the limb, around the bony areas, and these osteolytic lesions. And I can't see it, but apparently there are cortical sinus tracts going into the sinus tissue. This was in 2017, and then once again in 2018. I'm sorry, the cuts are not exactly the same. Unfortunately, due to flexion contractures, it's rather difficult to get the cuts at exactly the same area to show also all these beautiful looking lesions. Okay, so in between all of this, just before, he's obviously had a lot of histology, a lot of cultures being done, a lot of biopsies, and unfortunately, really nothing going. Non-specific inflammation, no granulomas. Histological report, subacute synovitis, no granulomas. Biopsies done. MTB, nothing. MTB gene expert, again, nothing. Fungal, nothing. And he grows a Staphylococcus capitis ×1, which we thought was not significant. So now we were like, oh gosh, now what? So as I said, with Prof. Loebscher, we decided to ask this gentleman to come back now in March for further workup and to be admitted. And as I said, for an aim to do an arthrodesis. But unfortunately, with these MRI features, it was decided that the best way forward for him was to actually do an above knee amputation with the aim of then doing sending him to orthotics so that he can be able to at least walk around, because he is currently still working for this in the construction area. So at least help him with his livelihood. And so we then sent him, obviously we had the above knee amputation, and tissue was sent off. And in his case, it was compatible with an actinomycetoma. And just to tell you about case, well, actually, I mixed the cases around, my apologies. The first case was also actinomyces, and that's the gentleman with the abscess on the back. I'm now going to ask Dr. Studler, Janet, to just go through some of the histological stuff. She's kindly sent us photos, and I think the images are really awesome to look at. And this is his. So, Janet, it's all yours.
Thanks, Tari. Yeah, so about 2 weeks ago, we received several fragments of tissue that were very small, between 1 to 3 centimeters. I'm not sure what happened to the amputation. And we processed the specimen. What we could see were fibromuscular tissue fragments, bone and cartilage, and dense inflammation, and then these sulfur granules. So in the center, you can see the basophilic organisms, colonies, and then they're surrounded by this fiery eosinophilic phenomenon, which we call the Splendori-Hoopley phenomenon. And we also did a gram stain, which showed that the center of the colony was filamentous gram-positive bacteria as well.
Thank you, Janet. Okay, so I'm just going to talk a little bit about actinomyces at the moment. So there was this group by Stunninger et al., and they looked at the different types that you can get. And in their cohort of 392 patients, Actinomyces mayeri was the most common. But in other cohorts, they actually show that Israeli is more common than mayeri. And then I've highlighted the Israeli and the mayeri and the Odontoticus as these are the ones that are associated with disseminated disease. But please keep in mind that this is a rare pathogen, but to have disseminated disease, I think, is even more rare. So yeah. And well, when do you need to think about these patients? So you need to be suspicious if a patient comes to you and they're complaining of this long-standing history of possibly mass-like features or sinus tracts or granules. And importantly, when you do imaging, if you see progression through the tissue planes, you've also got to be concerned about that. And I think especially with this gentleman's case of the bone involvement in soft tissue, he went to multiple healthcare providers beforehand, and obviously has received antibiotics on a number of occasions, and that obviously went to no avail, unfortunately for him, and he just progressed. So once again, this refractory or relapsing disease, often antibiotics are not working. You need to be suspicious of this. And clinically, well, the most common is orocervicofacial, found in 50% of cases, then thoracic, then abdominal pelvic, musculoskeletal, and rarely you do get CNS or disseminated disease, as I mentioned a bit earlier. And now, well, granules. I've been told before you will be able to make the diagnosis by just knowing the granules, and it does make sense. However, I think to try and remember what each color represents and which bug it is quite challenging. So I've tried to make a bit of a flow diagram to try and remember this, but essentially the granules can be actinomycosis or they're eumycotomas. So U means true fungi, and those would be pale to gray granules, and that would be Scedosporium, Fusarium, black granules, Magirella, Cuvellaria, Exophalia. I've just chosen some names that I've recognized before. There are a lot more on this list. So just to keep that in mind, this is not an extensive list. And then if they're white to yellow, Actinomycosis, Majuriae, Nocardia, Actinomyces, and then Papavarnavas, and then yellow to brownish Streptomyces omalensis, and then red to pink Actinomycosis pelletieri. And then let's go through what could be the differential diagnosis for this splendor Hupili phenomena, because initially I thought it was just part of Botuliomycosis, another very interesting disease that I'm sure has been discussed previously on these forums. But essentially you can think of parasitic causes, cutaneous larva migrans, schistosomiasis, bacterial causes as well. We recognize these ones: Nocardia, Actinomyces, Botuliomycosis, and then your fungal causes could be Aspergillus, blastomycosis, and then Amalaceae furfu folliculitis. And then I thought to myself, well, Sanford says penicillins are the way to go, but what's the data surrounding this? Are they resistant to other antimicrobials, and can you use penicillins in all cases? So this was a large study. It was 392 patients. It's the one I mentioned a little bit earlier. And they showed that ampicillin sulbactums, so we've got ampicillin South Africa, 360 strains were tested and 360 were susceptible, so 100%. Tetracyclines, not a bad, 97%. I want to show you metronidazole are not great, and neither are the quinolones. I know only 4 were tested, but none were sensitive. And in other reports also, quinolones are definitely not recommended as first-line treatment. And as one can imagine, penicillin, 100% sensitivity, as I said, with the ampicillin, which is good news. And then, well, I had a next question. I was like, well, where does this, the data suggests, well, you should treat these patients for 2 to 6 weeks with IV antibiotics and then consider oral. So what basis do we have for this? And unfortunately, there's not a lot of data that I could find. But this was a retrospective review of, please note, thoracic actinomycosis of 40 patients. And again, the numbers are very small, but what they did for 17 patients is they treated them with surgery and antibiotics, and 16 had a favorable outcome. And importantly, 3 of the 17 didn't actually receive any antibiotics, but still had this favorable outcome. And that's obviously then says to you that surgery alone, in some cases, may be an option to do. And where this issue about giving IV antibiotics comes in now is in this group over here, 18 of 23 received antibiotics alone and had a favorable outcome. But the 5 that didn't have a favorable outcome were the ones that only received IV antibiotics either for 0 or well, from 0 to 2 days. And the other thing that you need to take into account is the duration of the symptomatology that the patients had. Those with longer duration of symptoms and disease are more likely to fail therapy in this cohort. And then I found a nice article in CID. It is a bit old, but it's still, I thought it was fantastic looking at the history of how patients would treat actinomyces back in the day. So as you can see, goes all the way, spans back to 1945 until 2003. And I'd like to point out also that, as you can see, the number of patients are very, very, very small numbers. And interestingly, I can't remember which study it was, but they were saying, we are now giving massive doses of penicillin to these patients to try and treat their actinomyces. But their massive doses in comparison to ours, I think, is quite different. Theirs was 150,000 IUI for these patients. And I also bring you to the next column where, how did they treat them? For what was the duration of treatment? And as you can see, it's very variable. 31, 49, 84, 18, 104, 10 days. So there's no real there's no real data to support how long to go for, but some people have said, which we'll get to the next slide, is you can consider a few months of treatment for these patients. So the duration of treatment will also depend on a number of factors. And as I explained earlier, it will depend on the duration of symptoms, the extent of the disease. So let's take our patient that with the musculoskeletal involvement. He's obviously had a long-standing disease with extensive disease, and to the point where we were chatting about him, they were not able to amputate all of the area or debride all of the muscle without going up until essentially I think almost up into our hind quarter. So there is still quite extensive disease in this gentleman. In comparison, if you compare it to the patient one who just had an abscess on his back, where that was excised and cleaned quite nicely, and we don't expect there to be much disease afterwards, you could probably give him a lot shorter duration. And also you need to obviously follow up these patients and check their response to treatment. And the people suggest that doing CTs or MRIs of the areas to see how the disease is looking is probably the best way to go for it. And well, now the treatment options. This was from a review article by Wong as well as from Up to Date. So for mild disease, you can consider 2 to 6 months, and then for severe disease, 6 to 12 months. So I think for our gentleman with the musculoskeletal, we might err on the side of caution and give him a longer duration of treatment, but I will hopefully be following him up in the clinic. And let me tell you what we did for our patients. So we gave the patient ampicillin IV 200 milligrams per kg per day, and then we're going to give him amoxicillin for 2 grams, as I said, for 6 to 12 months. And then the other patient we treated with penicillin 6 million units, 6 hourly for 2 weeks. And then we were going to change to amoxicillin 2 grams, 12 hourly. And importantly, for the gentleman with the actinomycosis of the musculoskeletal system, he also had concomitant organisms. So he had a Streptococcus pyogenes as well as a Staphylococcus aureus. And there is a little bit of controversy whether you should treat those bystanders, or if they're just innocent bystanders, or if you should treat them at the same time. So we actually did opt to treat them as well, seeing that on all biopsy specimens, Strep pyogenes and Staphylococcus aureus were isolated. So thank you very much. That's me. And thank you very much to Janet and to Prof. Loebscher for helping with this very interesting case.
Well, thanks very much, Tari. And if you can stop sharing your screen, and thanks again to Janet, to Dr. Stadler for not only joining us today, which is great, but also and giving input, but also for welcoming us yesterday to review the full range of the histology and for providing that. That's wonderful. And thanks very much, Tari, for your presentation. So again, if people would like to raise hands, can I ask the pleural effusion, what happened in that case, the first case you showed? What was surgery? Sorry, I wasn't quite sure if was surgery performed, and what's happened to the pleural effusion?
Sure, thanks, Prof. So surgery was performed only to debride the abscess on the back, and the reason being is the radiology didn't indicate that there was. It looked more like a neighborhood inflammation of the pleural effusion, so they felt that it wouldn't be necessary to go in. And I was quite concerned that maybe this is an empyema, but because the patient was doing so well and this effusion was very small, we decided to rather treat it conservatively. And I'm going to review him in the clinic to see how this effusion looks. To if it obviously is still there, then we've got a problem. We'll probably need to address that, put needles in, and see what comes out. But I hope it's just a neighborhood inflammation.
And the lung on the CT was normal?
Yes, it was, well, normal, sort of. He had plate atelectasis. I suspect that might be due to the pain that he might have had from the surgery, but otherwise the lung was fine.
Okay, because I certainly remember, Gary, your patient from many years ago, who had the pulmonary thoracic and went all the way through to the anterior chest wall. Graham, and then Sean.
Thanks, Tari, for a great presentation. Just two brief questions. One is both relating to the second case. What do you think the mechanism of spread to the knee joint was? And secondly, kind of in retrospect, how could the diagnosis been made sooner at the other healthcare facilities that he visited?
Thanks, Prof. Mankis. Sorry, I should have mentioned this. I did say it in my history, but I didn't link it up. He used to be a soccer player, and he says to me he fell many times on the field. So I suspect that might have been his port of entry. The other option is he was a construction worker as well. So I'm not sure if he might have bumped his leg on the construction sites. So that would have been, I thought would have been his mechanism of entry. Sure, to make the diagnosis at the peripheral hospitals, I think it's a very difficult diagnosis to make, seeing that it takes so many years for these patients they go through many healthcare providers, and it's not a common disease, and I don't think a lot of people know about it. And I suspect you need to, before you send it for to the histology department, I suspect you need to tell them that you're suspicious of this, and then they'll be able to do certain stains on it. But I must say that splenohupli looked like it's quite easy to see. Well, when we saw the bone images, otherwise I think it's just difficult to make a diagnosis.
Had histology been sent off or was just cultures done?
So I'm not sure about in private, but in 2017 and 18, biopsies were sent. Yeah, but I think it was only one biopsy per year, essentially.
Thanks. So just before coming back to Sean and Chad, the 2017 X-rays you showed, I mean, even the plain film clearly showed lytic lesions in the head of the fibula, even, and so you would expect the person you would hope that somebody would be referred for more specialist assessment. Actually, I mean, I think this was a miss. I think there was a litany of missed opportunities, probably, but yeah, there you go. Sorry, Graham, did you want to come back on any of those issues?
No, and I'm just interested in other people's thoughts, about what could be learned about making an earlier diagnosis. Obviously, one thing would be more biopsies and the staining with that specific question in mind. But I'm just interested in other people as to how the diagnosis might have been made earlier in this man, because he seems to have struggled with it for many years.
I think the problem is having an index of suspicion. I mean, if you see somebody with grit or whatever coming out of sinuses, then, or mainstream pretty major deformity, and you don't get the answer quickly, I would hope that one would then send up for further, upscale the type of consultation. I think that's probably, and then obviously education and learning around these things. But
basically, it would have meant more biopsies that actually get to the diagnosis. Would have
yeah, or somebody who's seen. I mean, when you maybe it talks also to the need for more infectious diseases specialists, because if anyone who sees sinuses with granules coming out, immediately will, if you're trained to think about it, you think about that. So I guess it's that issue. I don't know if Sean, Sipa, and Chad have thoughts about this, but maybe Sean, I think you were next, and then Chad, and then Sipa.
Yeah, I was actually going to ask a similar question and make a similar point. I mean, I think chronic osteomyelitis is a difficult problem in general that gets mismanaged, and that's actually what this is. And just to emphasize Mark's points, I mean, we actually made this diagnosis at the bedside. And I don't remember if we did, but there was definitely a discussion about even starting empiric therapy for actinomycosis just based on the clinical presentation. So I think it just emphasizes the need to have specialists seeing patients with chronic osteomyelitis earlier. And also I was wondering, I mean, the most common cause probably is tuberculosis, right? So now, did this patient ever get TB treatments empirically or at some point?
Not as far as I know, Sean.
And then, I mean, just to kind of reflect on Graham's question, I just think, just a thought and then a question for the microbiologist and maybe the pathologist is, I mean, I think multiple biopsies is clearly the answer, because, I mean, there could have just been sampling error and missed the diseased kind of tissue. But, I mean, is there a laboratory, a microbiological factor or a pathological factor that is important to consider before or at the time of sending the sample to request to make this diagnosis? Or could it be diagnosed in the laboratory just on a sample, even if the clinician doesn't raise this as part of the differential diagnosis?
So the good news is that we've got Chad up next. So Chad, and obviously other micro colleagues. Chad, I think you had probably a different point, but if you...
Yeah, that was part of it. So to answer Sean's question, we do need to know in advance if that is a diagnosis under consideration. So we can do a modified acid-fast stain that will differentiate nocardia and actinomycosis. But having said that, nocardia is weekly acid-fast staining, so that's not really a specific test. And then we need to put up specific culture media under specific conditions for extended cultures. And we won't put this up routinely unless we see evidence on gram stain of branching or gram-positive bacilli, which we don't necessarily always see. So, so to answer that question, we might not have made the diagnosis directly. Once we have growth on the specialized media, there's quite distinct characteristics of these organisms, and then we can go on to do 16S PCR on the growth for identification, but 16S directly on the specimens is a bit iffy. So in this case, we've done 16S PCR directly on the tissue and hadn't picked up actinomyces. Having said that, we also didn't pick up the streptococcus or the staphylococcus, so that's something that we do need to look into. So my question was, given that the acid-fast stain is not necessarily specific, or it's not necessarily sensitive for nocardia, salty grains are not specific for either the splendor or Kupfli reaction can also be non-specific. So how do we know that this is not nocardia? And also given that actinomyces is kind of an oral organism and tends to be upper body and nocardia, as far as I understand, is that not correct?
No, I disagree, Chad. I mean, firstly, yes, of course, you've got a variety of diagnostic tests there that aren't particularly specific, but the finding on the histology of what the granule looked like in the bacteria that were seen there was, I think, along with yellow granules clinically, and the sort of duration is very much for actinomycosis. And actinomycosis can be, you know, an infection that affects the body in general. And I mean, you know, yes, you have the orocervical, but there's pulmonary and the thoracic leading onto the skin, and there's joint and bone and even multi-system. So I'm happy that this isn't nocardia, that this is actinomycosis. I'm not sure what others would feel. I'm going to come to Sean's, sorry, to Sipo's point, and then we could perhaps circle back and ask our other microbiologists if there are any other issues. I mean, you can also just take the granule, can't you, and crush it and stain. I mean, that's another diagnostic test in the laboratory.
Yes, yeah, that's correct. You just stain it, you just crush it with a cover slip, and then you stain it, and you can see, yeah.
Yeah. So Sipo, over to you. Thanks, Elizabeth.
Yeah, no, thanks, Mark. No, I was just going to say that the problem with this condition often is that when people do biopsies, they just do them sort of untargeted. And one of the things we've seen of the, I've seen over the years is that, especially if you have this history of granules coming from the sinus tract, is either actually trying to retrieve granules or biopsying close to the sinus tract, because you might get these granules, which is helpful in trying to nail this diagnosis. I mean, the cases I've been involved with over the years is that often, these patients have been to multiple practitioners, and people have tried multiple things and just not have thought of actino as a cause. And just my second point was that I think in Tari's talk just about therapy, the important thing here is antibiotic therapy. Surgery isn't the first modality, because often, because of the tissue involvement, and when patients come to you, you're going to have very destructive surgery. Often, sometimes it's not just soft tissue, it's bone. And, you may actually, as happened in this case, this man has had to have an amputation. But, it's antibiotics. Yes, there is a role of surgery, but that's not the first modality.
So thanks very much, Sipo, for that. Just before asking, we're right at the top of the hour, so we're going to finish very, very shortly. But Janet, Dr. de Stadler, I mean, have you seen many cases of actinomycosis over the last few years at GSH? I don't know if you've had any experience other than this case.
No, this is my first case.
Okay.
Yeah.
It'd be interesting to know how many we've seen. I mean, as I said, I remember Gary's case very well, but not many others. So Elizabeth, Hafsa, Adrian, any last comments? Amanda, any last comments on this? If not,
no, thanks, Mark.
Thanks, Adrian. Elizabeth?
No, I just was wondering though quickly, how long does it take for the sinus tracts to develop?
Tari, do you know for sure? I mean, it's usually a chronic issue, but my understanding. But
sorry, Elizabeth, I actually don't know how long it takes for these sinus tracts to form.
I think it's a fairly long process. So because for each of these, the deep-seated infection obviously starts first, whether it's in the lung or in the oral cavity, and it tracks through. So it takes some time.
Okay, thanks.
Okay, so